This might, oh, that sounds better. Thank you. So perhaps I will just repeat my gratitude to the organizers of the Congenital Disease University Oncology Conference for allowing me to contribute and participate in a small way. And I'm pleased to speak today on the subject of standard chemotherapy for ovarian cancer, and specifically, what are we waiting for? What I'd like to do is speak to a couple of different areas. First, a little bit about the context, but I'm assuming that this audience is well familiar with the overarching elements of ovarian cancer. I would like to spend a little bit of time talking about whether or not ovarian cancer is truly a single disease, because I would submit that what we're waiting for is to actually understand how many diseases make up the entity of ovarian cancer, and how does that guide our optimal therapy. I'll then talk a little bit about the first-line standard therapy as I see it. I will talk some about second-line therapy, and then acknowledge that there are some unresolved issues still within the domain of ovarian cancer treatment. Again, I suspect this is familiar. We know that this is a common cause of death amongst women who suffer from cancer, with high fatality rates. We know that in early stage disease, which is uncommon, but there is a relatively good chance of surviving this disease with 5-year survival figures of upwards of 92%. But by the time we get to the other stages, that 92 has dropped precipitously to approximately 30%. And regrettably, if we look at the survival curves over the course of the last several decades, we see that this has been relatively static or flat. We look here and see 1-year, 3-year, and 5-year survival figures over the course of the last 50 years, 30 years, not having shifted dramatically, despite what we're led to believe are significant advances in surgery, systemic therapy, and other. And even if we turn to the literature, I think one of the articles that I like to quote, because I'm from British Columbia, is the Lancet in 2011 published worldwide cancer survival rates, and noted that the best possible benchmark were 5-year survival rates for women with ovarian cancer in British Columbia, only at 44.1%. So if that's as good as it gets, we're not doing very well. So, is this a single disease? Well, having asked the question, I think the answer is evident. It is not. We used to think of this as one disease, but I'd like to just walk you through briefly the fact that there are at least 5 different diseases. We know that the large majority are high-grade serous cancers. Most of these have TP53 mutations. About half of them have BRCA dysfunction. And those two things combined seem to create a unique chemosensitivity to high-grade serous tumors. This is the traditional classification of ovarian cancer. We classify it by its cell of origin. So we look at the germ cells, sexually stromal cells, stromal tumors, and then epithelial tumors. And characteristically, we have enunciated 4 specific histologic types. But I think our knowledge is maturing, and we are now able to be much more specific. We felt that all these tumors were to have had the same cell of origin, the ovarian surface epithelium, but I think we now know that there's at least 5 diseases embedded within this. And as we look at the histopathology literature and the genetic literature over the course of the last 5 years, I think most authors are landing on a definition of at least 5 subtypes of epithelial ovarian cancer, each of which behaves differently and requires different therapy. And this is the endometrioid carcinomas, clear cell carcinomas, low-grade serous carcinomas, mucinous, and then the high-grade serous cancers, which make up, as I say, about 50% of the category. If we look at the endometrioid and clear cell and ask how these fit in as ovarian cancer, We know that this makes up about a quarter of all epithelial ovarian cancers. Almost all of these patients, if one looks hard enough, do have evidence of endometriosis. And it has been speculated that these are actually cancers originating in endometriosis. One of my colleagues that I get to work with, David Huntsman, published in the New England Journal 2 years ago, looking at ARIDA1A mutations and recognizing that there are high-frequency somatic mutations in ARIDA1. This is a chromatin remodeling gene, not just in the actual tumor, but also in the adjacent endometriosis and cancerous tissues alike, suggesting that this likely represents a molecular pathway starting in the endometriosis and extending into an actual cancer. These diseases have a clinical course more likely to be localized to the pelvis, less likely to respond to chemotherapy. We've seen that worldwide. They may be more radiotherapy sensitive, and they may even be hormonally sensitive, behaving similarly to uterine cancers. It is complicated by the fact that endometriosis is quite common and malignancy is uncommon. Less than 3 to 5% of women who have endometriosis actually develop endometriomas, and endometriomas themselves may be the risk factor for this type of malignancy. So it's uncommon. If we move into the low-grade serous tumors, these tumors tend to be indolent and rare. They're not particularly chemosensitive, and I think many of us have treated women for long periods of time with this type of tumor. They may well be related to low malignant potential. We very frequently see a pattern histologically with numerous pneumoma bodies. They may be hormone responsive, and they are not at a molecular level in any way related to the high-grade serous tumors. They usually are not associated with p53 mutations. We may actually see mutations in the KRAS pathways, BRAF, and also in the ERB2 pathway, much more commonly in low-grade serous tumors, which characterizes them very differently from the high-grade serous tumors. When we look at mucinous tumors, these are rare. These are the ones that we see surgically, as you can see in this particular picture here. Large, perhaps slow-growing tumors. By and large, seeing actual malignant transformation is uncommon. Very often these are benign or at least borderline tumors. They respond poorly to conventional chemotherapy. We do see a molecular pattern evolving where there is a significant proportion of these that overexpress HER2. And perhaps these may be tumors that would best be suited to targeted therapy. We have within our own institution recently started a protocol using Herceptin on this type of tumor. So the optimal treatment remains yet to be defined. And again, another one of my colleagues published in the BMC Cancer 2 years ago on these tumors. We also know that some of these mucinous tumors may be HPV positive tumors. And I was saying to our colleagues here in gynecologic oncology today that I think as we start looking at HPV and its association with cervical cancer, there's a whole host of other disease sites that we really haven't started to get our heads wrapped around yet in terms of the role that HPV plays as an oncogenic virus. If we look at the high-grade serous tumors, these are the classic circumstances that we see ovarian cancer in. They're usually high-grade. The pictures that you see before you here of small bowel serosa and mesentery are fairly characteristic for those of us that are involved in the surgery of women such as this. And this is the type of cancer that makes up about 70% of the cancers that we see. If I can use a little molecular cartoon here just for a moment, the actual molecular targets are the ones that in this particular disease I think are where the excitement of the future lies for optimal therapy. If we're looking at the endothelial cells and looking at VEGF receptor inhibitors, that's where the category of drugs including sorafenib, sunitinib, cediranib, pazopanib, and also the more exciting compound from Boehringer Ingelheim, BIBF 1120, is also seen as a VEGFR inhibitor, as well as an EGFR inhibitor on the endothelial cells. And we're just starting to see early data related to ovarian cancer with these drugs. If we look at the actual tumor cell, there are a variety of receptors that have been identified for which new smart molecules have been developed. The folate receptor antagonist, farletuzumab has been piloted through the GOG in terms of phase 1-2 studies in women with ovarian cancer. Similarly, even at the level of the PDGFR inhibitor, BIVF 1120 has a role in this particular area as well. We also see some of the inhibitors of the HER2 and the EGFR receptors, including cetuximab and erlotinib, both of which seem to be active in ovarian cancer, probably acting through that pathway. And I think we're only just starting to see some of the early data related to PARP inhibition with such agents as the new AstraZeneca compound 2281, which has shown some very early preliminary results. What I want to point out with this, these are targets that have been identified in the population of women with high-grade serous tumors, and not the other tumors, endometrioid, clear cell, and mucinous. I'll comment a little bit on this, both in this talk and in my subsequent talk. Some of you may have been aware that within the domain of what we call the GCIG, or the Gynecologic Cancer Intergroup, which is a cooperative group of trials, organizations conducting phase 3 trials with women with ovarian cancer. We have 29 international member groups now. Every 5 years there's a consensus conference held to come out with a series of statements regarding the conduct of trials in the population of women affected by ovarian cancer. This was in 2010. I had the opportunity to host this meeting in Vancouver, and this was the consensus statement that was issued as a result of that intense 5-day workshop, and I don't think that has changed substantively from this particular slide. This was published in full with the background data in the International Journal of Gynecologic Cancer in 2011. I also want to make a short comment about the fallopian tube, not because the fallopian tube is short, but because the commentary will be. But there's no doubt that this is seen as another facet of treating women with ovarian cancer that I think is both enhancing and complicating our understanding at the same time. We recognize that many of the women, particularly those with BRCA mutations, who are undergoing prophylactic BSO, we see that it's at the distal end of the fallopian tube that the occult cancers in the majority of women are occurring, not on the ovary. This has led to some significant review and thinking, and could this actually be the source for high-grade serous tumors? If we look at what the evidence is, we notice that in about 75% of cases of advanced ovarian cancer, we see changes of intraepithelial cancer in the distal end of the fallopian tube. And that may be total destruction of the tube, or else even to the extent of intraepithelial disease. Very often this is unilateral involvement of the fallopian tube juxtaposed to the side where the cancer is evident. This rather makes sense intuitively if you think about it. The native histology of the fallopian epithelium is actually serous in its appearance. It's a large surface area with all of the various fimbrial and fimbrial ends. We see the transformation to a Mullerian-type epithelium, and malignant transformation or invagination of the tubal epithelium on the surface of the ovary looks very similar to this. So compared to the ovary, the fimbriated end of the fallopian tube is huge. I won't go through all of the articles. There have been a number over the last 2 or 3 years suggesting for these high-grade serous carcinomas that the fallopian tube may well be the site of origin on this method. And again, just in pictorial representation, the fimbria as a site is less likely to be recognized as a primary tubal cancer, but there is a unique region here with a large surface area exposed to biologic events that may well just be the source of these malignancies. When we say what are those events that impact on this area, certainly there could be an inflammatory aspect to this. We know that women with pelvic inflammatory disease do have a higher incidence of ovarian cancer. We know that tubal factor infertility predisposes both to endometriosis and ovarian cancer. And we also know that the oral contraceptive pill use will decrease the incidence of PID and the risk of serous cancer concomitantly. I might just skip over this slide for the purposes of time, other than the fact that there is some fairly good basic science information related to the ascending infection theory. And
And just summarizing what I've attempted to say to date, we see the increased incidence with certain factors, PID, infertility, decreased incidence with tubal ligation and oral contraceptives, and furthermore with pregnancy. And suddenly, from a pathophysiology perspective, this theory makes sense. One of the questions that's then asked is there a precursor lesion if this can occur in the fallopian tube, similar to what we see in cervix, potentially in colon, and also in breast, all of which are thought to have precursor lesions. It's always been said that there was no precursor lesion for ovarian cancer. However, as we look more and more towards the tissue that is being removed from women, either prophylactically, we see more evidence of tubal intraepithelial carcinoma, such as you see depicted here. The other important thing is, from a molecular characterization perspective, if we actually look at these tissues in women who have intraepithelial carcinoma, both heretic and sporadic cases are characterized by P53 overexpression, and that correlates with the underlying mutation and high proliferation rate. And these changes are seen characteristically not just in the normal fallopian tube, but also in the in situ disease and in what we think is a full-blown high-grade serous cancer of the ovary, suggesting that the actual molecular defect is something that is at core, fundamental to the development of these lesions and not casually related. So it appears that there is a precursor, and it may well be that this is in the fallopian tube, and that's where these tumors arise from. So why is this important, other than the understanding of the disease and directed therapy? Certainly in Canada and the US, about 30% of women across the population undergo a hysterectomy, the majority of whom have their ovaries and embryonic gland of the fallopian tube left in place. And we also might anticipate that if the tubes were removed at the time, would this have an impact on the long-term outcome? So what I've tried to do in that first piece is just suggest to you that we are not dealing with one disease. Each of these forms of epithelial ovarian cancer has its own pathogenetic and molecular characterization that will actually alter the treatment that we recommend. So shifting gears a little bit then, and we go into first-line therapy, what are we looking at here? And what new knowledge do we actually have over the last 5 years that might lead us to make a different statement about standard therapy? Well, first and foremost, Deb Armstrong and her colleagues in the GOG, I suspect this article is familiar to most of you, describing the use of intraperitoneal route, cisplatin and paclitaxel in women with ovarian cancer. And again, this was a third study with level 1 evidence suggesting that the intraperitoneal route was preferred. And many persons would ask, how many level 1 randomized phase 3 trials do we need to prove a point? This was the third one. There have been many other studies looking at the actual doses and drugs that are involved, but the bottom line of which is I believe that we have now demonstrated that the IP route does carry a survival advantage. There's been a lot of work looking at dose densification of therapy. This was Dr. Kasumada's report from the Japanese group, again with a phase 3 open label randomized controlled trial, showing that weekly paclitaxel actually did infer an overall survival benefit. More recently, a couple of studies looking at the VEGF inhibitor bevacizumab. This was the ICON study, and also paralleled by the GOG 218 study. Both of these studies, and there's the GOG study, again, many of you will have read these reports. Both of these studies do show an increase in progression-free survival. The larger one, the GOG study, did not show a change in overall survival, and this has occupied many statisticians over the last 18 months debating whether we're seeing a crossover effect from access to bevacizumab, which was much more available in the GOG study than it was in the ICON study, or are we just not going to see an improvement in overall survival? That is, does bevacizumab prolong the disease but doesn't do anything to cure it? And then finally, I put this slide up as one of the more remarkable ones over the last 5 years as well, looking at maintenance therapy. And this was a study again through the GOG GOG, led by Maury Markman, looking at the use of paclitaxel in a maintenance regimen, and again, no improvement in overall survival. So, what is it that we have actually learned over the past 5 years? There have been several studies, including one led by Canada through the GCIG, looking at topotecan. The addition of a third agent does not improve overall survival nor progression-free survival. GOG 182 also contributed to that body of knowledge. We do know that the intraperitoneal route shows a survival advantage. We do know that weekly paclitaxel has been reported in at least one phase 3 study to show a survival advantage. We do know that bevacizumab shows an improvement in progression-free survival. Whether that's an appropriate endpoint for a phase 3 study as opposed to overall survival remains yet to be seen. And at the present state of knowledge, maintenance therapy does not appear to show a survival advantage. So I talked about the consensus conference from 2010, published in 2011, and I just want to touch on a couple of the statements that came out of there because I think they reflect what we do know and what would have to be considered as standard therapy. As with any consensus conference, it was an international group of colleagues that came together to chair the committee. We ended up asking 5 specific questions. I'm not going to read these slides. As I say, they're available and were published last year. This talked about the endpoints, and it's very highly relevant to bevacizumab trials. Is it important that we look at progression-free survival, or is overall survival still the benchmark? And I think the conclusion from the consensus conference is that progression-free survival is important, but not as important as overall survival in studies such as we have been speaking of. I won't go, these are phase 2, phase 3 study endpoints, not directly related. Second question was, are there any subgroups defined by, I think I'm being given a hint, hurry up. Are there any subgroups defined by tumor biology who need specific treatments and specific trials in order to formulate that? And I think it's fair to say that these 3 categories were 3 areas or 3 groups of patients that it was strongly recommended that separate trials be developed for these women, and they could not be included or should not be included routinely in broad-based trials amongst women with high-grade serous cancer. So these are those with a clear cell carcinoma, those with a mucinous carcinoma, those with a low-grade serous cancer. Now, if there are not specific trials for these women, they should be included in the regular phase 3 trials, but should be considered as subgroups in the analysis because of what I hope I said to you at the start of this presentation. Prior to 2010, the consensus conference before that was held in Baden-Baden, Germany in 2004. And at that point, the question was asked, I'm going, sorry, somebody's racing. And at that time, the standard treatment that was recommended must contain a taxane and platinum agent administered for 6 cycles. And that was upheld in 2010 as remaining the benchmark for the standard of therapy in phase 3 trials. You'll note the second bullet is acceptable additions or variations in dose, schedule, and route of delivery should be supported by at least one clinical trial demonstrating non-inferiority or superiority to standard taxane and platinum. And I think that statement as of January 2013 still remains relevant. There was a statement made about what is the role of modifying dose schedule, and delivery of chemotherapy. And this is a subject of ongoing study. The GOG study looking at IP therapy by Deb Armstrong. That was an intense 24-hour regimen, and I think most of us have shifted to intraperitoneal protocols now, which are outpatient-based protocols, short-term and using carboplatin rather than cisplatin. But there still need to be further studies to define the optimal regimen of IP therapy. I also note on this from the consensus conference, 2 particular approaches were flagged. One was the dose densification using weekly paclitaxel, I've just spoken about, and second of which was the IP therapy. Finally, what role does surgery play? I will comment. I guess I won't comment. I will comment on this in my subsequent talk, but I won't read this slide. I think you can see it here. Surgical staging is recommended as mandatory. The ultimate goal is resection to microscopic disease. Documentation must be an imperative for all those operating on women in this population. And I've actually included the statement there, delayed primary surgery following neoadjuvant chemotherapy is an option, but I'll expand upon that in the subsequent talk. So, which targeted agents could be regarded as part of a control arm in ovarian cancer clinical trials? This was in, this consensus conference was held in June of 2010, about 2 weeks after the results of the bevacizumab GOG trial had been presented. Certainly the US feeling is that bevacizumab must be a mandated part of all standard therapy, and I think you see that in the current GOG trials. My own impression is that's not a view that's widely held globally, and certainly the Europeans, Canadians, and others have not raced to make bevacizumab mandatory. Therefore, the consensus statement suggested it could be incorporated in the control arm as a result of the two trials, the ICON and the GOG. But probably more moderate to say that these trials support the investigation of further agents that target angiogenesis. The optimum duration and dose of bevacizumab remains unclear, and extremely important in future trials in this regard, particularly when we get into novel therapeutics like bevacizumab. The impact on quality of life and patient-reported outcomes is substantial, and those need to be included as key outcomes in such studies. I just wanted to touch on a couple of high-level, at a high level, on a couple of the trials that are ongoing there at the present time. The Tarceva trial was a trial that was recently completed by the EORTC group, and this looked at the addition of another inhibitor compared to a control arm as a consolidation strategy. The trial included 835 women in this trial, and the results were presented. And you can see here, this is progression-free survival between erlotinib or observation, and I think most of you would agree those curves are superimposable, and there is no substantial difference by the use of erlotinib in a maintenance setting. The Aurelia trial was a second-line trial that has also been looking at the addition of bevacizumab. That trial continues to be analyzed, looking at overall survival as well as progression-free survival. But again, one of the important parts here is that this trial does show an improvement in progression-free survival, but we also see it coming together at the two arms with time, and whether that ever will be translated into an overall survival improvement remains yet to be seen. And again, in trials such as this, patient-reported outcomes when using these novel therapeutics is critically important to be accommodated. It's not just a comparison using a chi-squared test or any other statistical analysis on the survival curves. We must look at the patient outcomes. A number of studies have been spawned. I talked earlier about the Boehringer Ingelheim's agent BIBF 1120 with both VEGF and EGFR inhibition qualities. This is the major trial being completed, led by the Germans, AGO. Nearly 1,400 patients have been accrued to this. We're anticipating an analysis and presentation of their early results at ASCO this year. Again, their more recent trial looking at the agent pazopanib, and I think all I would really say is what you're seeing are a number of studies taking standard therapy taxane and platinum with the addition of a small molecule, primarily looking to interrupt angiogenesis, primarily VEGF inhibition, but with others, and trying to understand whether we can push that curve out a little bit further in terms of overall survival. Regrettably, I don't think we're seeing the blockbuster yet that we need to see in this disease. This is the current OVAR-17, the AGO trial, looking at trying to answer the question both about concurrent bevacizumab, but also the consolidation question and how long that should be carried on for. continue to see some of the studies looking at dose escalation, and can we do it within each patient. This was a Scott Rock study. The Australian New Zealand group joined into this. And again, no significant difference in outcomes between the two groups, between dose escalation or standard dosing. And I think we probably have beaten that one to death. We're not likely to see an improvement in dose intensification other than the weekly paclitaxel strategy. Not to focus on the details of this study, but there's only one point that I will make on this. This is the current GOG intraperitoneal trial, and you'll notice that GOG has incorporated bevacizumab as standard in all arms, all experimental and control arms, on a go-forward basis. This is Japanese, and I'm not going to say anything about that one. Again, I commented that dose densification is not likely to be, I don't think anyways, not likely to be showing us significant benefits. But again, the GOG has continued to put bevacizumab as a standard agent in their armamentarium for women with primary ovarian cancer. I'm going to go over that one. One of the studies that is still ongoing is actually led by our Canadian group, and some of our colleagues from Montreal and Toronto have led this one. OV21 is what we refer to it as. I think we've demonstrated that there is a survival advantage for intraperitoneal therapy. I think that we have demonstrated that there's comparable outcomes for neoadjuvant chemotherapy versus upfront chemotherapy or upfront surgery followed by chemotherapy. And therefore, the next logical question to ask is, can we gain any benefit by using neoadjuvant chemotherapy, operating on the patient, and then using intraperitoneal therapy? And that's what this study is designed to answer. It's actively accruing. It includes SWOG, it includes GECO, and I don't have the specific numbers off the top of my head as of this month, but it's been accruing fairly well. A lot of discussion as to what the next ICON study will be, and this is the collaborative group led out of the UK, but it's multinational as well. And as you can see here, there has not been an embrace of bevacizumab in all study arms. It's not to preclude it, but this particular trial is seeking to address whether there's the opportunity to test the question of weekly paclitaxel in the setting of both delayed primary surgery and immediate primary surgery. This study has not been fully finalized, even though it started randomizing patients, because there is an opportunity to do an early analysis with this many arms in the study. So this remains yet to be seen. The only takeaway on this slide, this is again one of our Japanese, one of the studies from the Japanese group testing irinotecan and cisplatin. But the key point here is that they've now focused in on clear cell carcinoma. This is a different disease in those high-grade serous, so that we're dealing with multiple different diseases, and this is going to have to be looked at through separate trials. Similarly, the UK group, particularly out of University College London, has come forward with a new trial looking specifically at mucinous epithelial ovarian cancers. And I would only make the pitch that these are uncommon diseases, will require multiple centers participating in that. So the takeaway, first-line standard therapy must contain a taxane and platinum agent, and I won't read the second bullet there. That has not changed. I think in the interest of time, I'm just going to skip to this last slide has unresolved issues. I'll talk a little bit about it in my next talk, but the extent of surgery remains as a substantial issue. How ultra-radical should radical be? Timing of surgery, there remains a passionate discussion globally as to whether there's an appropriate role for neoadjuvant chemotherapy followed by interval delayed surgery, or what role that will play. The role of bevacizumab, I've tried to map out for you already that there are some countries that believe this is standard therapy. There are other countries that don't believe it has any place in standard arms of trial protocols. And then maintenance therapy, dare I say, in some ways won't go away. Where that will fit with new agents, it's difficult to say. Certainly the preliminary data looking at bevacizumab has shown some improvement in progression-free survival, but it remains to see whether that will translate into overall survival. So with that, I will stop. And this is not Jeddah. This is actually it's actually Whistler, just outside of Vancouver. And we are not able to enjoy the heat that you have here, but we do have some blue skies and white mountains. So thank you very much indeed.
Thank you, Dr. Stewart. We can allow the questions.
Thank you very much for the condensed presentation. I'm Najla Al-Mari, oncologist from Riyadh. I have just one question regarding bevacizumab. If you don't mind to give us your view, how much the effect of bevacizumab for optimal cytoreductive surgery versus minimal residual disease? How much it will affect the progression-free survival and or if there is any difference?
I'm sorry, just to clarify the question, how much impact is there from residual disease?
Giving bevacizumab on microscopic remnant disease, like i.e. there is no disease left or there is minimal residual disease, how much that will affect progression-free survival, adding bevacizumab with carbon taxol regarding the root?
Well, I think the question you're asking is one that people feel passionately about, that the addition of bevacizumab, I think we can say, has been demonstrated to show an improvement in progression-free survival. That is greatest in the group of patients who have no residual disease. There is some benefit in those who have small volume macroscopic disease and almost no benefit in those with gross residual disease. So I think at the present time, an optimist would say that the addition of bevacizumab has its greatest impact on progression-free survival in those patients with no residual disease.
Thank you very much.
Proceed.
Thank you, Prof. Stewart, for this nice coverage of the standard chemotherapy for advanced ovarian cancer. My question is coming from experience with one of the patients that we treated here at King Abdulaziz University Hospital. A 40-year-old patient presented with advanced ovarian cancer and pleural effusion positive cytology, stage 4 ovarian cancer. We elected to go for cytoreductive surgery, and she had actually good cytoreductive surgery with residual of less than 1 centimeter. She responded with systemic chemotherapy. We gave her the standard chemotherapy. We reached to 6 cycles. However, the CA-125 is still more than the normal. So the question at that time, after we finished 6 cycles, where to go from there, with the question whether we should continue, since she responded for another 3 cycles of the taxanes and platinum, or should we give her the maintenance weekly taxol, or should we give her second line, or should we just wait and see what will happen, or should we switch her to the second line chemotherapy? Can you please comment on this and help us with that?
So first, I'm assuming that if you operated on her, I'm sure she would have good cytoreductive surgery, so thank you. Second, in terms of answering your particular question, this is not an uncommon situation where women have their surgery, have optimal chemotherapy to follow, and after 6 cycles may or may not have evidence of residual disease clinically. I'm understanding the woman that you described has no clinical evidence of disease, but an elevated CA-125. I can tell you that in our own institution, we have stopped following women with CA-125 in this setting, and the reason for that is that we chose not to treat CA-125s. We did an analysis of our own data, and it is about to be published, that those women who have had optimal surgery, full 6 cycles of appropriate chemotherapy, no clinical evidence of disease, and an elevated CA-125 will recur. And therefore, if you're going to recur, we would not
there does not appear to be a benefit therapeutically in terms of giving them 9 cycles or 12 cycles or 15 cycles compared to the 6 if they haven't responded then. And furthermore, if they haven't responded to standard chemotherapy with a taxane and platinum agent, we would probably go to second line or phase 1 and phase 2 studies. So how we would approach a person like that, if she was feeling well, no clinical evidence disease, stop watching her CA-125. When there's clinical evidence of recurrence, we would put her on a phase 1-2 study.
Thank you.
Last questions from here. Can you go to the mic, please? You can ask a question.
Thank you very much for the comprehensive review. I'm already a medical oncologist. I think you have nicely elaborated that ovarian cell carcinoma is not one disease, there are different types. Regarding the targeted therapy, I think you agree that it should not be the way we have seen in the clinical trials. We have given immunotherapy for every patient. It should be subcategorized. Like we have seen a Western failing, not showing overall survival. We have seen Interceiva is not showing advantage. I think you should agree, you would agree that it should be group categorized rather than all ovarian cancer. My question is regarding if you can comment on ovarian platinum resistance.
And I'm sorry, I might have actually missed it.
Two points. One about the targeted therapy should be, in clinical trial, it should be subcategorized to certain groups rather than all ovarian cancer, because ovarian cancer is not one disease, epithelial ovarian cancer. The second is if you don't have convention about platinum resistance disease.
Well, I think if I understood your question, you're asking one of the questions that we're very, very interested in at the present time is having characterized certain pathways at a molecular level of ovarian cancer and recognizing that they do all respond clinically in a different way, what is it about one group that will allow them to respond to PARP inhibitors and another group that developed platinum resistance very quickly? And is there a molecular characterization that we can actually correlate with the development of platinum resistance and timing and so on? And our basic science group has actually jumped into this one and trying to see if we can generate some of those answers, because I think one of the points you were making is that there are different pathways at a molecular level, but at a therapeutic level, we need to think differently and approach them differently, which is actually the parallel that I think medical oncologists have drawn for many years in other diseases where they're not all the same. You do need to actually approach it differently. But I have a sense I may not have actually answered your question.
That's right. The second question about platinum resistance.
And I think in terms of platinum resistance, we have always, I say we, I think many authors anyways, have felt that platinum resistance was more a question of timing, how soon or how early it would develop. Furthermore, there's been an entire strategy, at least in ovarian cancer, to prolong the platinum-free interval on the basis that there's something magic about that. I think what we're actually going to find out is that that's probably not the right route to be going down. I think we're going to find out that there's probably a molecular pathway that would better help us not only to predict that, but to upfront, not worry about platinum resistance, but just treat that patient differently. So it's still not an area that I think we have a clear understanding on in ovarian cancer.
Thank you, Dr. Stewart. Give me great pleasure to introduce our next speaker, Dr. Abdulazziz. Dr. Abdulazziz is practicing currently in Saudi Arabia Hospital. He's a graduate from Beirut, Lebanon, then he did his residency in Sherbrooke University, then fellowship from Dalhousie University, and practiced for almost 8 years in Montreal at Maisonneuve-Rosemont. And since the year of 2000, for the last 13 years, he's an obstetrician, gynecologist, and gynecologist at Saudi Aramco Hospital. The presentation will be about cervical cancer, primary and secondary prevention. Dr. Aboud.
To talk about this, I was assigned the good subject of cervical cancer prevention. It's because I think we are making lots of advances in this topic, and it's I think the best of the topics that went on today. First of all, as an introduction, I can say that most doctors are attracted to cure disease. However, most people prefer not to have the disease, and that's the basis of what we call prevention. To put things into perspective, just to tell you that this is data, US data, where we can see that for cervical cancer, one woman out of 128 will develop uterine cervical cancer during her lifetime. And we can see here that this is number 10 in rank, but that's in the US, and depending on where we are in our geographical area, this rank may change. We'll see that with the latest that I saw in the Saudi Cancer Registry, we are about, cervical cancer is about ranking 8. If we are somewhere in Africa, it's about ranking 2 or 3. So prevention, what's prevention? Depending on the course of the disease, where we apply the preventive measure, we can call it primary prevention, secondary prevention, or tertiary prevention. Primary prevention is to prevent the disease from occurring at the beginning, where we target the reason for developing the disease and prevent it from occurring. Secondary prevention detects and cures disease in the asymptomatic phase. For our topic, I'm going to talk about the pap smear, the HPV test, and the colposcopy. Although definition-wise, this could be questionable because pap smear, HPV, and colposcopy most often detect precancerous disease, and we intend to treat them before reaching the cancer stage. As for tertiary prevention, this is just to prevent complications from an established disease. So hopefully I'll be able to highlight you on HPV vaccine, pap smears, HPV testing, and colposcopy, all those for as prevention of cervical cancer. A good screening test could have dramatic results. This is a typical graph showing since application of pap smear, the significant reduction in the incidence of invasive cervical cancer, which in the US since 1950, when pap smear became more widely used, the incidence rate dropped from around 35 to those days is around 7 or 8. So what about the numbers in our area here? This is, I'm going to talk about, like I had two sources of data. This one is from the WHO in their report, in their 2007 report, and we have also the Saudi Cancer Registry. The last one that I saw was also the 2007 version. So we can look at this red square here that represents Saudi Arabia, and I just attract your attention about this figure here, which is the age standardized rate of 4.6. And if we like to compare ourselves with our neighboring countries, and we like very much also to compare ourselves to North America, and those are the figures in Canada and the US, 7.7. One very peculiar thing also is if we can look at this figure here, which is the age-standardized mortality rate in Saudi Arabia, which is 2.5, which is exactly similar to what happens in North America. So in Saudi Arabia, this is a little bit over 50% of our patients, whereas in North America, this is just about 30% of their cases that dies. So this tells me one thing, that we are lacking behind in either early detection and screening. Figures from our own Saudi Cancer Registry. The issue with the Saudi Cancer Registry is that they have a special account for Saudi nationals and another account for non-Saudis. If we look at the Saudi nationals here, the age standardized rate is 1.9, but if we check also the non-Saudis that are living here, the age standardized rate is 4.2, and probably the figure that we have in the WHO is probably the combination of those two. So here I took the numbers from the Saudi Cancer Registry and made the total divided by age group, and the green is the total. And I just put this slide to highlight the early, the youngest patients with cervical cancer diagnosed here. This is in 2007, where we had one case of a Saudi national and one case of a non-Saudi. So that makes it 2 cases in 2007 between the ages of 25 and 29 years old. So that's young. Along the years, those are the number of cervical cancer cases since 1994. We can just appreciate a little bit that in the late 90s, the numbers were about 80 cases a year. In the early 2000s, the numbers became 90 cases per year, and the last one jumped to 105. So there is a slow but sure increase probably in the numbers. We may put a reason of better reporting maybe to the Saudi registry. However, whatever the reason is, we do have to think for future planning that this number will be increasing. In order to talk about preventing cervical cancer, we need to know what are the real risk factors. I put in as a first place the presence of human papilloma virus, which is present virtually in all cervical cancers, and also as risk factors, any lifestyle activities that increase the probability of exposure to HPV does the same thing. Other things, decreased immunocompetency, like I'm thinking here about HIV, for example, or patients with transplants, and other cofactors like smoking or the presence of other STDs. One very, very important thing is that most of the patients that are diagnosed with cervical cancer have not had any screening test, or at least did not have any adequate screening test. So HPV is very important. HPV contain about maybe 100 genotypes or varieties of HPVs. Not all of them are cancerous. We have a special group that we call the high-risk types of HPVs, which is a group of about 14 or 15 genotypes that we see them in various percentages in cervical cancer. The two most frequent ones, and this is regional estimates from the WHO, number 16 and number 18, both together make 67% of the cervical cancer. and to a lesser percentages the other high-risk viruses. Now, not every HPV infection goes into cancer. The vast majority of HPV infections are transient and they clear spontaneously, especially in younger women, less than age 30, where most of them would be cleared within a few months to, on the average, to up to 2 years. With persistent infection, this may progress to precancerous lesions, and those are the low-grade and high-grade dysplasias, where still many of them may regress, and a small part would develop into cervical cancer. So prevention may be applied here or here. I'm going to talk about those. Now, first of all, the pap smear that detects pre-invasive neoplasia. We have two techniques that we use for pap smear, and both are acceptable. The conventional pap smear, which we fix on a glass before sending to the lab, and the second one is a liquid-based thin layer preparation. There has been plenty of talk and papers in order to compare the two methods, but up till now there is no clear winner between the two, and both are acceptable. When we do it, we can collect for other things like HPV testing or other things, but the very important thing is that if a lesion is visible, don't take a pap smear and wait for the result. Biopsy that lesion. How do we report it? In the vast majority and the places we do report it according to the modified Bethesda system, the 2001 modified Bethesda system, where I put all the categories here. The most important one to consider is the specimen adequacy, and that tells me if I can rely on the result that's given to me or not. If the specimen is not adequate, then I cannot really rely completely on what they are telling me. On the second column here is the result itself, interpretation. They can tell me it's negative, and that's fine. Or they can find anomalies, which could be from the squamous type or the glandular type. And those anomalies may include either pre-invasive disease, low-grade, high-grade, or squamous cell carcinoma. But let me remind you that this is pap smear, not biopsy, so all those, whatever result we get here, need to be confirmed later with a second test. Other than reporting, so how frequent we have abnormal pap smear, abnormal pap smears, I couldn't find local figures for percentage of abnormal pap smears. So those are US figures. We call it the pyramid, where out of 50 to 60 million women screened, we get 2 to 3 million ASCAs, and that's between 4 and 5%. We get 1.2 million of low grade, which is about 2-3%, and 300,000 high grade, which is about 0.5%. And the tip of the iceberg is 10,000 cancers a year, and those are US statistics. What are the recommendations to whom we do pap smears? I'm going to show you the most recent US recommendations that came out about 2 months ago, and also I'm going to talk to you about a local pap smear program developed in Jeddah that Dr. Khalid Said also explained it to me. So first of all, those are most US professional organizers from the American Cancer Society. Here we see the US Preventive Task Force and the American College, and they agree mostly on the same things, where pap smear at age 65. In young ladies up to age 29, do the cytology every 3 years, irrespective of previous cytologic history. And when the patient is 30 years and older, we have two options: either to continue with the 3 years cycle of pap smear, or either this or do what we call the co-testing, which is a combination of a cytology plus HPV testing. But then when we do both, we will be able to do it only every 5 years and not every 3 years. So all those bodies, they have those both methods. But as we can see here, they prefer to do the co-testing rather than the pap smear alone, and that's only in patients or in women aged 30 and older. Of course, now we see more and more patients who have HPV vaccine who already got it, and in those patients, those screening methods should not change. And of course, if their cervix, if they don't have a cervix, the patient had a hysterectomy for any reason other than high-grade dysplasia or malignancy, then it's not indicated to do any screening. Not important. So this leads me to talk about the gender cervical screening program, how we are doing it here. And this is a slide that was gracefully given to me by Dr. Said. And as we can see here, this is a scheme for patient age 30 and more. So what is happening here in younger patients is probably they are continuing to do the pap smear every 3 years. But for 30 years and older, married since more than 3 years, it is done as an HPV test, hybrid capture 2 that Dr. Said told me. So if this is negative, it is only repeated after 5 years. However, when this is positive, there is a reflex pap smear done, and depending on the reflex pap smear, if the pap smear is negative, then they repeat the HPV testing in a year, and depending on the test, if it is positive, it goes to colposcopy, and if it is negative, it goes back to the 5-yearly checkup. If the pap smear is positive with a positive HPV, it goes straight to colposcopy. Now, the interest of this program, as I was told, that they are inviting, of course, all women to join it. They can register into a website, which I put here the coordinate of the website. It is free for everybody. And a second thing which is very important in this program is that there is a recall system with it, where the recall is done for results, following on the results, following on any treatments, and following on the repeat testing, and also follow-up for the second round and third round of screening. Now, following the screening, this is the real primary prevention of cervical cancer, is preventing the cause of cervical cancer, and we do have available HPV vaccines since about 2006. We do have 2 commercially available vaccines. One is bivalent, targeting HPV 16 and 18. The other one is quadrivalent, targeting HPV 16 and 18, plus HPV 6 and 11. We've seen that 16 and 18 were the 2 most frequent viruses in cervical cancer, and the 6 and 11 are mostly responsible for anogenital condylomas and low grades. Both of them have been approved following extensive randomized controlled trials with very big numbers of patients, and they both reach very good efficacy in HPV-naive patients. We see results of 93 and 98 and 100%. However, in intention to treat patients, which are patients who are from the general population, some of them have already contracted HPV in the past or had an abnormal path in the past or whatever. And in those general population, of course, then efficacy will go down up to 30 and 40%. Now, how do we reach such a high efficacy rate in the HPV naive, up to almost 100%? Although the viruses cover only HPV 16 and 18, is because of the cross coverage of some of the viruses. As we can see that we do have a family of viruses which we call phylogenetic associations. And this family, where we have the HPV number 16, is very similar genomically to other viruses. So when we vaccinate somebody with this virus, it cross-covers to those other ones, and as well for the HPV-18 with its own family. For recommendation, who do we need and how do we give those vaccines? Intended for prevention, as I said. It does not treat HPV. It's very wrong to give the vaccine because somebody has HPV and you want to treat it. It does not interfere with pre-existing disease. It's most effective in HPV-naive people. That means, of course, people who were not exposed to HPV. This is when we get the best results. Therefore, it is ideal before sexual exposure. In most of the countries where this HPV vaccine is given in a program, we give it in young ladies between the age of 9 years and 12 years old, and in most programs they have catch-up vaccines up to till age 26. We do have studies that makes the vaccine efficient up to age 45, but of course the older the lady is, the less efficient is the vaccine. Previous abnormal pap smear or previous HPV disease is not a contraindication, but efficacy is less. Duration of the protection, we do not know exactly how long the protection will last. However, we do have now 8 years of time from 2003 or 2004, since we have started giving those vaccines, and it is still ongoing. So it is for sure more than 8 years, but we don't know how long will it go. As for safety of this vaccine, it has been found to be really safe. Most of the problems are local injection sites program and problems, and most of the serious events were not linked to the vaccine itself. To conclude, of course, prevention is better than cure. We don't need to say that. But as we commonly say, an apple a day keeps the doctor away. We can also say a well-applied program of cervical screening and HPV vaccine keeps cervical cancer away, and that's very true. And as for us clinicians, because this is an almost always preventable disease, it has a precancerous state that we can detect it. We do have means to prevent the majority of it. We should consider each case of cervical cancer as a failure to our medical system. And thank you very much for your attention.
Thank you, Dr. Abdul, for this primary, secondary prevention. The floor is open for question.
Yes. Can I ask a question, please?
Yeah, sure, please go.
Okay. Thank you, Dr. Abdul, for this excellent review on the topic. We did start the screening program for cervical cancer. We hope it's a regional screening program. We hope as we show our success of the program, we can generalize it to be a national screening program involve the whole kingdom. And so far we had the program for the last 1 year, and we think we are doing really good for that, and we hope that we can add the Ministry of Health take it from here and spread it to the whole kingdom. My question is, do you think that cervical cancer vaccine or HPV vaccine should be part of the routine immunization in the kingdom?
First of all, just with regard to your first comment regarding the regional cervical screening program, if we want to bid on a significant success, there will be no significant success in a cervical screening program if it is not undertaken by a higher authority such as government or ministry or something like that. Certainly I hope that whatever you have started here would go beyond the local university to involve some administrative areas and administrative decisions so that it becomes a national screening program. And this is when we will have really the results that we would be aiming for. With regard to the HPV vaccine, first of all, as I showed you the initial figures, in Saudi Arabia, although our prevalence for HPV is less than in the US or in Canada. However, and this is what I wanted to highlight to you during this presentation, is our mortality rate is similar to what the mortality rate is in Canada. And so we are not doing a good job, one, in screening, and prevention also count in that number. So of course, if you ask me my opinion, if we should implement something in the way of cervical, of HPV vaccine, I would recommend it because we have mortality figures that correspond to other people who are doing it, and they have it. I don't have any figures of local incidence of HPV in the local population, but we do have the mortality rate of cervical cancer which are there. So should we recommend it? I think we should discuss it. We should, now in the absence of a government or a ministry decision for that, I think we should expose it to any patient, tell them what is available for prevention, and as I said, this prevents HPV. I am sure that the problem in this setting would be to mentally convince people that although this is an HPV vaccine, we are vaccinating against an STD between brackets, but it is something that may save lives.
Okay, thank you, Dr. Abdul. Next, we'll move to the next session, our next speaker. It's my great honor to introduce actually my classmate, Dr. Abdalhani. Dr. Tahia Lakwiti, she graduated from King Abdulaziz University Hospital, and she went actually to did a scholarship in radiation oncology. It was in Prince Margaret Hospital in Toronto, Sunnybrook Regional Cancer Center. She currently she is working in King Abdullah Medical City in Mecca, since April 2012, as a consultant in radiation oncology and the head of radiation oncology department. Dr. Tanish is going to present about radiation in gynecological cancer, where we stand.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank the organizing committee for inviting me for this presentation. The topic today is radiotherapy in cervix cancer, where we stand. So I selected one of the advanced in treatment of radiotherapy treatment in cervix cancer, which is image-based brachytherapy. So in this presentation, I would like to outline the history of brachytherapy in cervix cancer. Then the second part of the talk will be about image-based brachytherapy, definition, option, rationale, benefits, then some of the challenge of image-based brachytherapy. As we know, intracavitary brachytherapy combined with external beam radiation is considered the standard therapeutic option for invasive cancer of the cervix. Brachytherapy is driven from the Greek words for short distance and referred to the therapeutic use of radioactive material placed within short distance from the tumor. Patients with locally advanced cervix cancer require brachytherapy after external beam to increase the likelihood of survival and optimal outcome. So the efficacy of brachytherapy relies on improved therapeutic ratio by delivering high dose of radiation treatment to the tumor while sparing the surrounding structure to the minimal dose. This is one of the advantages of brachytherapy in cervix cancer. So this is some overview about the history of brachytherapy in cervix cancer. So we moved from 2D dimensional planning to CT based, and there is a recent advance in using MRI based planning for brachytherapy. Also the source has been changed from using low dose radiation treatment, where the patient has to be in a closed room for 3 days to having to complete the radiation session, to high dose brachytherapy, where you can deliver high dose of radiation over a few minutes, then patient can be discharged home and coming the next day for her second fractions. Also the prescription has changed from 2D point prescription on the 2D to use more volumetric prescription as we use in the external beam radiation. Also the instrument has changed over the last 2 decades. From simple tandem ovoid, now we have more options using rings and needles, where you can deliver radiation treatment based on residual tumor, and you can modify your dose. So previously, in the old days, we used the two-dimensional image for identifying the application and identifying our source. So what we used to do to insert the applicator, then we have 2D image and we have to put contrast in the rectum and bladder and the vagina to be able to identify the anatomical barriers. Then we have to identify the prescription point, which is, we use to define it at 2 centimeters, which is point A, which is 2 centimeters above the cervical os and 2 centimeters lateral to the tandem, which is point where we think it's the paracervical tissue is. And really point A did not correlate significantly with the complication and local control rate in various forms of cervical brachytherapy. And this prescription to this point, without regard the cervical anatomy, and can lead to substantial underdosing of the large cervical or large residual tumor. And the location of point A is determined based on application geometry instead of the actual anatomy of this patient. So we moved in the last decade to image-based brachytherapy. So why? We can identify the disease and the target by imaging. We can define the normal structure and visualize the anatomical variation, and we can conform the dose to the tumor while trying to spare normal organ around it. So we moved from 2D to image option of ultrasound, CT, MRI, and there is recent studies about using PET scan for defining and planning brachytherapy in cervix cancer. So this is just some images about ultrasound in patients with intrauterine tandem. Here you can appreciate the anatomical definition of the uterus and the tandem inside the uterus and the other organs. And CT, it gives us more definition of the cervix and the surrounding organ around it, which is the critical organ, bladder and rectum. And you can appreciate the tandem inside the cervix in relation to the critical structures. MRI, it gives us better definition for the soft tissue, as we all know, and we can define the critical structure like rectum and bladder more easily. Here, just a comparison between the definition of the CT and MRI in the same patient, so you can appreciate that MRI can give you better definition, which is the dotted line in comparison to CT. And recently there is some work about using PET scan in defining the residual disease and using it for planning of cervix brachytherapy. So the talk is going to be mostly about CT-based brachytherapy, which is the most available imaging technique in most of the radiation center. So the introduction of CT-based planning of cervix cancer brachytherapy was easy because most of the oncology center or radiation center has CT simulator within the center, and it was easy transition from 2D to 3D. So when we first introduced the CT planning, we had some problem with a lot of artifacts from the older applicator, which we used to made of a little bit heavy metal, so we had a lot of artifacts on image. This led to also invention in the applicator itself, so we are now using more CT compatible, CT MRI compatible applicator, which is mainly made of tungsten. The issue of using CT-based brachytherapy, it's going to add more time to the process of planning. Most of the time like 45 minutes to the insertion procedure and planning process. But even when we started the process, we were using it as image to confirm the application and confirm the prescription point. So it was easy to define the tandem even on the scout image and just define the prescription point on the scout image. Another advantage of using the CT, you can appreciate the anatomical variation of the uterus and cervix and on the CT image on the sagittal view. We can define the adequacy of the applicator. If, like in image A, you can appreciate that the applicator is short, so in this case we had to take the applicator out and we inserted it again. The other advantage to comment on the presence of the applicator inside the uterine cavity rather than inside the muscle. So we had a lot of advantage of having CT images to define the adequacy of the applicator.
2 minutes.
Also, it shows any perforation of the uterus, because if you see in the 2D image, you cannot appreciate if the uterus inside the uterine tandem inside the uterus or not, because one of the issue, if you had perforation of the uterus, so you have to take your tandem out, repeat your application after a few days. So then we moved from using the CT as an image tool to introduction of 3D planning, using it as a planning tool in brachytherapy. So we use it like what we use in external beam. You can define your volume, you have your isodose line distribution, so you can appreciate the coverage of the tumor by the appropriate dose while sparing the normal structures. And we moved also to prescribing to a volume, like what we use in external beam radiotherapy. You can define your volume. We have now different definitions, and each target volume should have the appropriate dose for this prescription. You can shape your isodose distribution, and you can cover your target as we use in external beam radiotherapy. Also, we can appreciate the critical structure. So in the past, when we used to use the 2D planning, it was difficult to identify the sigmoid, so the sigmoid wasn't considered as tolerance organ, but nowadays we can contour the sigmoid and it's considered as a tolerance organ. So what we used to use rectal dose did not represent the sigmoid dose, but nowadays we can contour the sigmoid and we can define it as a tolerance organ. Also, we by 3D planning introduced the new concept of dosimetric analysis. So we use the dose volume histogram and define the minimal dose in most irradiated volume as the 2 cc volume dose of the rectum, bladder, and sigmoid, and we have certain definitions for each 2 cc volume. So with each fraction, we make sure that we have reviewed these doses to critical structures, and we take it in total with the external beam and brachytherapy. So in 20 of 23 patients, which is 87%, the rectal and sigmoid dose on the CT-based planning were higher than the 2D planning when they compared the two planning process. And in 75% of those patients, the dose need to be modified on subsequent fraction to reduce the dose to the sigmoid and rectum.
Time. 30 seconds.
Okay. CT-based planning need to be done for each fraction. So what's done for one fraction, it's not sufficient sigmoid and bladder, and the rectum and sigmoid change relatively to 0.8 in 30% of the patient during the 5 fracture. Also, there is a change in the uterus and vaginal position from day to day, and also different in vaginal packing. Probably I'm not going to talk about MRI-based brachytherapy. But in conclusion, we can now delineate the target tissue as well as the organ at risk. And the inclination is to treat the intracavitary brachytherapy in a manner similar to external beam radiotherapy, so defining the target and prescribing dose to the target and trying to avoid critical structures. There is improvement in the outcome since in the introduction of image-based brachytherapy. The challenge, it's not available inside the OR. There is time between performance and delivery of dose, so there is a potential for tissue deformation and intra and post-operative anatomical variation. We had very good outcome based on the 2D point prescriptions, so we need to continue reporting on the 3D brachytherapy planning and the aim to achieve at least the same or better outcome with this kind of improvement in the planning process. Thank you very much.
We can have one question. So then we have 1 hour ahead of schedule. Thank you, Dr. Thani. We'll come back to Dr. Stewart, our last speaker. So without any introduction and further delay, Dr. Stewart will speak to us about the optimal and site reduction in ovarian cancer.
So thank you very much again. Thank you again to the organizing committee. What I'd like to do, I'll try and truncate my talk in order to meet your schedule, but is to try and offer a little bit of discussion around what defines optimal cytoreductive surgery for women with ovarian cancer. And I'd like you to keep in mind there has never been any randomized controlled trial related to the role of surgery in this disease setting, and I do not think there ever will be. So much of the evidence is at best level 3, some of which is level 5, which is referred to as best personal opinions. So the questions that I'd like to touch on: what's the appropriate surgical procedure? Who should perform it? When should it be performed? How do we ensure the quality of surgery? And are there some women who actually don't need surgery? So again, a lot of this does reflect the consensus work we've done with gynecological cancer intergroup. And the consensus statement that you saw earlier was in response to one of the questions in the conference in 2010. Surgical staging should be mandatory. It should be performed by gynecologic oncologists. The ultimate goal is cytoreduction to microscopic disease, and it suggests that there is some benefit with minimal residual disease, but the ultimate goal should be microscopic disease, and that should be the only setting in which the term optimal cytoreduction is used. Documentation is paramount in consideration of these, and delayed primary surgery following following neoadjuvant chemotherapy is still a consideration. And I think if there was any take-home message on this talk, this slide is it. So what's the appropriate surgical procedure? And I think most of us would agree that in an ideal setting, a complete hysterectomy with bilateral salping oophorectomy, whether it's done abdominally, robotically, laparoscopically, minimally invasive surgery, removal of the uterus, tubes, and ovaries is a prerequisite. And complete resection of all other visible disease. If there is no other residual disease, then surgical staging is required. In terms of how do we get to that recommendation in terms of surgery, probably Dr. Griffith is one of the first that published in 1975 when he noted that the outcome or survival in women with ovarian cancer was related to the amount of residual disease. This has been repeatedly quoted and
supported in the literature. He was for goat in 2008, a very eloquent description of how the size of residual disease after surgery was the single most important prognostic variable. And complete or optimal debulking is directly related to prognosis. Another meta-analysis that was done in the US by Bob Bristow. And Andreas Dubois has recently, again, confirmed the German experience that there is an advantage to women who have complete surgical reduction at the time of their presentation. Interestingly enough, Bob Bristow in 2002 actually went so far as to note that there was a 5.5% increase in median survival for every 10% increase in cyto reduction. And I will just put a plug in here that I think one of the weaknesses in these data is documentation of residual disease. As surgeons, we know how to measure residual disease. I think that is subjective, and whether we're saying less than a centimeter, more than a centimeter, very few places have actually gone down to metrics or pictures, video photography that does assist in documentation of what residual disease is. But Tate Thigpen has been quoted as putting forward the GCIG definition, which is the term optimal cyto reduction should be reserved for those with no macroscopic disease. And I think that gets away from some of the subjectivity. There's a variety of papers that have been out here. This is a paper put forward by the SGO. More than anything else, it was an abstract that was presented this year at the SGO. And a retrospective analysis, particularly of GOG 182. And they had identified a score assigned to the amount of preoperative disease and a score related to the complexity of surgery. And it was interesting in looking at the results of this. So this was a large number of women, 2,655 patients, but the preoperative disease score did predict overall survival and progression-free survival. Well, that's fine, that has nothing to do with the surgery. But the complexity of surgery, and the higher that complexity went, only related to the outcome if there was only microscopic disease remaining at the end of the surgical procedure, suggesting that anything short of that, that is small volume disease, less than a centimeter, did not have any bearing on the overall outcome. The surgical complexity has varied, and certainly a lot of the US authors and German authors have taken a very aggressive stance on what constitutes appropriate surgery. Dennis G. from the more Sloan Kettering group has had several papers, but the one I quote is from 2009, where he obtained an 80% optimal debulking rate, recognizing there was an increase in OR time, blood loss, and morbidity, but felt that that did correlate with overall survival and progression-free survival, but that was in a non-randomized retrospective study. Dr. Eisenhower in 2006 wrote about the need for extensive upper abdominal surgery, and again noted that there was an increase in morbidity and mortality, but felt that there was an improvement in overall survival compared with historical controls. Dr. Chang, this past year, an eloquent article on systematic lymphadenectomy, and did a retrospective review of 189 women, and felt that a systematic lymphadenectomy, pelvic and periaortic, did correlate with improved survival if it rendered the patient as having no macroscopic disease. I've just selected a couple of the more remarkable articles this past year. A group led by Dr. Zapperdeel was looking at 33 women that had undergone splenectomy, and felt that, that there was not a significant increase in complication rates, but it did allow them to achieve complete or optimal cytoreductive surgery. But some of the details of that were not identified. Lukacs this past year also reported on a large series, 527 women undergoing what I would have to consider as fairly radical surgery for ovarian cancer, including the procedures as you see here. But this article failed to provide any 30-day mortality or morbidity figures. The point that I make with this is that just because we can do the surgery doesn't mean it should be done. because we don't know about tumor biology. And a very nice editorial article, actually written by Al Cubbins in the year 2000 in Gynecologic Oncology, reflected that it may well be that tumor biology predicts more about the outcome and the surgery than anything to do with the surgeon. And it may well be that what we're doing with these radical surgical procedures and identifying overall survival are identifying a group of women who have tumors that can be resected rather than the skill of the surgeon. And that is what actually predicts the good outcome, is the tumor biology. Also, another one of my Canadian colleagues now in London, Michelle Prefontaine, did do a study looking at residual disease as measured by MRI post-operatively, correlating that with the findings of the surgeon at the time of the operative note, and suggested there was very little, if any, correlation between the operative note and the MRI findings in terms of size of residual disease. So as I've indicated, we have no randomized data. We do have increasing obfuscation of the literature by neoadjuvant chemotherapy, and we have no patient-reported outcomes related to those that have undergone extensive surgical procedures. So in terms of what is the surgical procedure, I will go back to my first slide, which is still, I believe, a total abdominal hysterectomy, bilateral salpingoophorectomy. We do have a little bit of data on who should perform the appropriate surgical procedure. A number of articles have shown that if a gynecologic oncologist does the procedure, the likelihood of the woman undergoing optimal surgical resection is considerably higher. Barbara Goff in 2007 reported a series where the volume of cases in an institution and the surgeon associated, the surgeon themselves, volume did correlate directly with the opportunity for optimal resection. That is, the surgeon doing one case a year had much lower rates of optimal cytoreduction than those that were doing 100 cases a year. Similar results have been documented elsewhere, Earl and Dubois with the German experience. Again, gynecologic oncologist is more likely to obtain optimal cytoreduction. However, the proof of the pudding is in what about survival? And when we look at this, there's a variety of articles that have been published. Elizabeth Junior, a radiation oncologist in Scotland, was the first to publish some data in 1999 showing that those women treated by gynecologic oncologists had improved overall survival. There have been several articles since then, most recently, Ayun, looking at the Scandinavian data this past year, 2012, demonstrated that those women treated, operated on by gynecologic oncologists had an improved overall survival when compared with a group who were operated on elsewhere. So it appears that who performs a surgical procedure does have an impact, and I think this statement, appropriately trained gynecologic oncologists functioning in an institution with an appropriate volume of cases in a centralized system, probably leads to preferred results. This has been a sticky one for the community of persons treating women with ovarian cancer. When should the appropriate surgical procedure be performed? The consensus statement, or consensus conference statement, suggested new evidence has affected the timing of this surgery and the extent of initial efforts to achieve optimal cytoreduction. This evidence needs to be accommodated in the design of new trials in this population. And I can say certainly when I trained in my fellowship, it would be nothing to consider a 6 or 8 hour surgical procedure for initial cytoreduction. I think most of us, with the exception of the US, have gone away from that now and recognize that the evidence suggests that neoadjuvant chemotherapy followed by integral debulking surgery has comparable results. Having said that, there's also a strong sentiment to the contrary, and there was in a series of consensus statements from the conference in 2010, of the 23 statements that were made, we achieved consensus, meaning all groups unanimously supported the statement, with the exception of one statement, and that was the statement related to integral debulking surgery. And as a result, there was a minority statement that was subsequently published by the German group and supported by some of the US group, that neoadjuvant chemotherapy cannot be regarded as adequate routine therapy as a strategy for advanced ovarian cancer and should be limited to selected patients. Having said that, there are data, randomized, phase 3 trial data that has been published. This is a study led by Ignace Vergote, EORTC 55971, published in the New England Journal. Analysis was completed in 2008. The primary endpoint of this study was overall survival. And I won't read through the study, you can see it here. It depends on either upfront surgery or no upfront surgery, but rather neoadjuvant chemotherapy. Published in the New England Journal, as I said, in 2010. And this is the overall survival curve. There is no difference between the two groups, whether they had upfront surgery or whether they had neoadjuvant surgery. However, there was considerably lower morbidity in the group that had neoadjuvant chemotherapy followed by integral debulking surgery. Under those circumstances, one could interpret those results as suggesting that neoadjuvant therapy is probably safer with the same results. Having said that, there have been a number of editorials and articles written to refute the results of that trial, suggesting that if one looks at the so-called fractional cell-kill hypothesis, that is, chemotherapy is a lot more likely to be of benefit with fewer cells, then why would you ever consider neoadjuvant chemotherapy as opposed to the surgery up front? Second of which is the Goldie-Coleman hypothesis could be used to speculate that by using chemotherapy in a neoadjuvant manner, you're increasing the number of mutations and subsequently increasing the likelihood of platinum resistance, which leads into other chemotherapy resistance as well. So there are a number of theoretical arguments against the use of neoadjuvant therapy. I personally think it was a well-conducted study. There's no doubt that there were concerns about the European-Canadian study that Ignace Vergote published. Number one of which is, as Dennis Chee points out again in an article this year, the median survival in the primary debulking arm was only 30 months, which is considerably lower than the best US results, which are usually closer to 39 months. So why is that? Was this a particularly poor group of patients being selected? Optimal cytoreduction was only achieved in 41% of women in the primary debulking surgery arm. This is lower than the 80%, which is often quoted in the US. Did this mean that surgeons backed off more quickly? Did this mean that surgeons were more objective? Did this mean surgeons were more realistic? And also there was a concern that in the primary debulking surgery, there was a group of approximately 23% of the patients that were stage 4, primarily with pleural effusions, but did that compromise the results and render the outcome in this group less? One of the questions that's frequently asked in terms of when surgery should be performed are those women that are referred into institutions such as this, having had a laparotomy, perhaps a partial laparotomy elsewhere. Is there any advantage to reoperating on those patients right away, or should they go on to receive chemotherapy and then integral debulking surgery? Again, the literature is but anecdotal. One report this year, 28 patients, 22 were reoperated on. 26 went on to have neoadjuvant chemotherapy. Again, retrospectively, it was felt that the overall survival rate was similar, and that complications were actually less in the reoperation arm. So does that mean we should be reoperating on these patients? Another paper from 3 years ago on 29 patients, again showed the median survival time at 39 months, which correlates well with our historical controls. So does that mean that reoperation is a good thing or a bad thing? Overall, I think it's fair to say that neoadjuvant chemotherapy and integral debulking surgery and primary debulking surgery can both be considered as standards of care. A quick word on how do we ensure the quality of surgery, because a lot of this can be subjective. And I'm very pleased to see that there's been a recent focus on what the quality indicators might be in institutions dealing with large numbers of women with ovarian cancer. The group out of Seattle, led by Barbara Goff, published just this past year some of the SGO measures looking at 537 cases of women with ovarian cancer and correlating that to outcomes. And what were the key findings? Number one of which was clear documentation of residual disease in the operative report. And number two was the performance of adequate surgical staging in the absence of disease beyond the ovary. Those were the two key things that correlated with the quality of the surgery. Similarly, a European study, primarily through the EORTC, they had 3 quality indicators. Number 1, surgery by a gynecological oncologist. Number 2, an institution with a sufficiently high volume of cases to be comfortable doing this. And number 3 was the frequency of removal of all visible tumor. These were the 3 quality indicators that they identified. But I do think as institutions, we now need to consider how do we ensure the quality of our surgery in these women. In the US, prompted by the American College of Surgeons, there is something now called NSQIP, National Surgical Quality Improvement Program. This is actually something that has come in place across the US in both community and university-based hospitals, and now in Canada, and actually is showing improved patient outcomes in a variety of different areas. The metrics that are currently in place extend to cancer care, trauma programs, and bariatric surgery. And I think this is an area that we'll see considerably more embracing of over the next several years. The metrics that they look at are in structure in the institution, processes within the institution, and outcomes, and tie that into direct patient outcomes, specifically in women with ovarian cancer. Finally, are there some women with ovarian cancer who do not require surgery? And again, the answer probably is yes. Not everybody with a suspected diagnosis of ovarian cancer requires an operative procedure. There are those women with comorbidities, and I think we've all seen them, and many of our medical oncology colleagues see more of these patients as they're asked to treat patients for serosal effusions, suspected ovarian cancer. There are those women with solid organ disease, and we see some of them with splenic and hepatic metastases. I personally think that that's something that has to be thought through very carefully before carrying out partial hepatectomy plus or minus splenectomy. We know that there are those women on CT scan with extensive retroperitoneal and small bowel mesenteric disease or disease in the port hepatis that is likely not resectable, and they probably do not benefit from a laparotomy. I've put age down here with a question mark because I think we need to look at the biological age of patients rather than the chronological age of patients. There's a number of women we operate on who are 85 years old, who biologically are functioning much younger than that, others that are in their 50s and are considerably older than that. And then finally, respecting that there are those patients who may well refuse surgery even after an informed consent discussion has taken place. Bottom line of which is there always will be some exceptions to surgery in ovarian cancer, but generally speaking, most women will benefit from that. So I will summarize with this last slide. I don't think this has changed. I'm still on my 20 minutes, so I think I'm within time. And actually, this was Vancouver a couple of weeks before Christmas, but it's still a pretty nice place. This is out of my office window, actually. So it's still a pretty nice place to work with. Thank you very much for your attention.
Thank you. Chemotherapy. Let's say a case with advanced ovarian cancer, 3C, and the plan was for neoadjuvant chemo. And after 3 to 4 cycles, the patient is not showing the optimal response or like suboptimal response from the chemo. At this point, would you consider trial of debulking, knowing that you may not achieve an optimal debulking, or you would switch to a second-line chemo? This is a very common debate in the tumor boards.
So we have looked at our own database in British Columbia on this group of women. So those are those women who've completed 3 cycles of neoadjuvant chemotherapy, whether it's 3 or 4 cycles, we usually use 3, and have not shown the anticipated response clinically, radiographically, or with CA-125. We do know that those women do poorly. They're not the ones that are likely going to survive their disease. So we are looking at prolongation of survival rather than cure of disease. Second of which is we also know that in the absence of resection of the primary ovarian tissue, they're not likely going to do well. So we do give this group every benefit of the doubt in terms of if it looks like they've had a reasonable response, if it looks like there's a lot of disease, but we probably will be able to resect it, we do operate on those women, but with a fairly low threshold that if there's any solid organ involvement, spleen or liver, we would not take those patients to the operating room. If there's extensive retroperitoneal disease, we would not take those women to the operating room. So I think we're going to see an evolution in managing that group of women.
And quite frankly, if they have not responded effectively, we do not continue with ongoing taxing the platinum. We switch them to phase 1-2 protocol.
Thank you very much.
Dr. Said.
Thanks, Prof. Stewart. My question for those patients with neoadjuvant for chemotherapy for advanced ovarian cancer, after interval debulking, is it enough to give 3 more cycles, or should you give, depending on the response, you can extend it to maybe 6 more cycles after the interval debulking?
It's a very good question. I had a couple of slides on that I pulled out in the interest of time, because intuitively one would think, well, 3 is good, 6 is better. Having said that, I know of no data to show that 9 is better than 6 or 12 is better than 6. And there does appear to be a school of thought, or a body of literature actually, that optimal results in terms of best correlation with overall survival and progression-free survival is at 6 cycles of chemotherapy total. And also increasing evidence that continuation of that, all we will see is increased toxicity and drug resistance develop. So I personally would opt for 3 cycles and then discontinue treatment. The difficulty you run into are those patients who have, and I think we've all seen them, who have a further 3 cycles, have now had a total of 6. Their CA-125 sits at 200. They may have a little fluid still on a CT scan, and what do you do with those patients? And it goes back to the question I asked, or was asked in the last session, is we generally would follow those patients until it was clinical evidence of progression.
Okay, so I do have a question. We do face every now and then young ladies whom they present with ovarian cancer localized to the ovary with probably a bit of an extension, and she has no children. What would be your decision if you ask her yes, she will tell you yes. That would be if there's any way to just remove one ovary and keep the other one, so that I'll have a higher chance, perhaps some chance of having children in the future. So what would be your recommendation of surgery?
And would that
epithelial ovarian cancer?
With stage 3 disease? Or? Yeah. So it's an interesting question. Obviously, you've been there. Our approach and my approach has always been to do anything possible to be conservative. And certainly, if the disease is confined to the ovary and there's no spread beyond the ovary, I would take out that ovary, follow the patient, and counsel her to become pregnant as she wishes to. If the disease has spread beyond the ovary, what I have done is usually had an informed discussion with the patient, indicated that the best evidence would recommend a total abdominal hysterectomy, bilateral salpine oophorectomy, and obviously remove her fertility and then follow that with chemotherapy. But I always do point out to them that I am aware there have been a fairly significant number of women who have chosen not to follow that recommendation, have only allowed us to take out one ovary, completed their chemotherapy, and then gone on with viable pregnancies. In our own center, we have not published those yet because I think we're up to about 11 or something like that. But there have been those cases that are self-selected, and I personally think that that's entirely appropriate. I don't think I can recommend it, but certainly if asked about it, or even if I haven't been asked, I do bring that up, that some women have chosen that pathway. Clearly the evidence with both paclitaxel and the platinum drugs in terms of any oocyte impact and future mutations and so on. There's a lot of good literature out there right now suggesting that we're not seeing the long-term implications that we had done with some of the other cytotoxics in terms of interference with viable pregnancies. So it certainly is possible. It's hard to recommend, but I think it's certainly feasible.
Just a comment from patient advocacy issues about the fertility preservation. So if she is to go for extensive surgery, do you allow for oocyte cryopreservation or fertilized ova
cryopreservation and from the husband and carrying on celibate uterus. Is it something practiced in Canada or not?
So it occurs in Canada. I don't want to say it would be our practice. Many patients will ask the questions. We do have a routine protocol where the patients are assessed by the Reproductive Endocrinology and Fertility Service. They are usually counseled that the data is inconsistent on ovarian stimulation in the presence of ovarian cancer and will that jeopardize their prognosis or not. I can tell you from my own experience, the large majority of patients, even once they've started down the pathway of consultations and so on, usually come back in and say, look, I've changed my mind, I just want to go ahead with the surgery. We have had a couple of patients, not in Canada, but being on the West Coast, it's pretty easy to run down to Los Angeles, who have gone down and had anything from surrogate pregnancies to frozen embryos and so on obtained. Had mixed outcomes, I guess. I am aware anecdotally of one unfortunate young woman who did that and came back with extensive disease and died fairly shortly. However, there have been others who I'm unsure of their pregnancy outcome, but survived from cancer. So it's an interesting question.
Last question, Dr. Malik.
Thank you very much. I would like to hear your statement regarding heated intraperitoneal chemotherapy with peritoneal stripping as a future for the epithelial ovarian cancer. If you have a comment on that, please.
I'm sorry, for chemotherapy in
heated HIPIC, intraperitoneal chemotherapy, heated.
With peritoneal stripping. Yeah. And I'll say we, because we always we do not use that in British Columbia. Our gynecologic cancer center is centralized. We have a total of 12 gynecologic oncologists, 6 medical oncologists, 4 radiation oncologists that form our gynecologic cancer team. I think we work very closely together. We meet every week to review the literature, and we have talked repeatedly about HIPEC and whether or not this is something that should be embraced. Our feeling to date is that the evidence remains interesting, but not sufficient to warrant bringing it in other than in the context of a clinical trial. And we have other trials that would supersede this at this point in time. Having said that, I know there's a lot of institutions that do use it. I think their experience is unfortunately anecdotal, still remains to be seen, tested in the format of a randomized phase 3 trial with overall survival as an outcome. But I think it does generate some interesting questions. So no, our institution is not using that. I await to see further data.
Thank you very much.
Thank you, Dr. Stewart. I'd like to thank all the speakers. We'll leave the podium to Professor Ahmed.
Actually, on behalf of the organizing committee, I'd like to thank you all for coming, having this conference successful. Without your participation and discussion, that wouldn't have been possible. And sorry to keep you till this time, but we won't take a lot of your time. In fact, we have discussed quite a few points. We've summarized the points with some of the respected speakers and participants, and we ended up with the 5 major recommendations out of this conference. And I would like to just present them to you and to tell you that this is what we are inshallah pursue, and hopefully all these will be taken seriously by the higher administration of King Abdulaziz University. The first recommendation is the need of establishing the National Cancer Institute in the Kingdom of Saudi Arabia. And inshallah this we will this has already been discussed, but we will pursue it further with the Minister of Health and all the other health sectors in the country. Number 2 is the need to establish King Abdulaziz University Oncology Center, and in fact we are proud of our King Abdulaziz University president, who did actually have the initiative of asking us to start working of establishing the King Abdulaziz University Oncology Center. Number 3 is to establish a national cancer screening program for breast cancer, colon cancer, and cervical cancer. Number 4 is to carry on King Abdulaziz University Oncology conference on yearly basis in collaboration with King Abdulaziz University Endowment. And I wish if Dr. Hassan Kauthar is here, but he is our partner, and I think we will have good collaboration to do it on a yearly basis. Number 5 is the need to have more research projects related to the field of oncology in collaboration with international institutes. And we have so many well-known international institutes that we will be proud to have collaboration with. Number 6 is carrying on the role of King Abdulaziz University in educating public about cancer and in its primary and secondary prevention. I think if we achieve these main goals, I think we will hopefully serve the community and serve the society in the Kingdom of Saudi Arabia. By this, I'd like to thank you all again for your attendance and for your participations in having this conference successful, and I wish you the best of luck, safe trip back home. Wassalamu alaikum.